Assalamu alaikum. Today we are going to discuss the case of right renal tumor and right radical nephrectomy. After pneumoperitoneum, we are placing the ports according to the triangular technique. This is the port for liver retraction, as liver retraction is really important and needed in right-sided simple or radical nephrectomy, and at times also needed in pyeloplasty and adrenalectomy, of course. So the first step is to mobilize the colon from the upper pole and then towards the pelvic brim. The important thing is to be in the proper dissection planes, otherwise the small vessels will bleed and will lead to red discoloration of the dissecting planes, and then it's really difficult to identify those planes. So the mobilization of the colon continues. We can see that the gonadal vein or the genital vein is now visible. The IVC is almost visible, so we are cauterizing the duodenum, which covers the second part of the duodenum is covering the IVC. Okay, next is to create a window, identify the ureter, and a window must be created lateral to the gonadal vein, as if you make it medial to the gonadal vein, this may lead to pulling and of the gonadal vein and thus avulsion of it from the IVC. You can very clearly see the psoas muscle, which shows the completion of the creation of the window. And then we dissect along the lateral aspect of the IVC in the gonadal vein and mobilize the lower pole. After we mobilize the lower pole, in the meanwhile coagulating the small vessels here and there so that they do not hamper our vision of the pedicle. A little bit of mobilization towards the upper pole. Once we mobilize the lower pole, we place another port for retraction, so the assistant is holding the kidney and the lower pole away from the IVC, and we can thus use both our hands to dissect the pedicle. Otherwise one can retract the lower pole with the left hand and then can only use the right hand for dissection, which is at times cumbersome. Here comes the use of the left hand. Care must be taken while holding the renal vein with any kind of traumatic instrument or the energy source, because inadvertent pressing of the button of the energy source may lead to rupture of the renal vein. We can see that there is a lot of adhesions between the renal artery and the vein. That's maybe because of the tumor microenvironment, which has led to the edema of the lymphatics around the artery. So we use the right angle. This is 10 millimeter right angle forceps, which is used to dissect the posterior aspect of the renal vein. On the right side we have a short renal vein, so we need to mobilize a good length in order to apply the hem-lock clips safely. Here we can see that the artery is surrounded by the inflammatory response of the lymphatics, so we are trying to find it here. The artery is seen, so now we can safely dissect around the artery using a ligashore. Using the ligashore makes it sure small vessels are coagulated. Now we use again the right angle to dissect behind the artery, as the plan is to place a clip which can reduce the supply to the kidney. However, the dissection posteriorly to the artery is not complete. That's why we were unable to apply the clip. So we try again, but there must be some tissue around the artery, especially along the posterior aspect and the superior aspect, which is hampering the application of the Hem-o-log clip. So we try again. As I mentioned earlier, care must be taken not to injure the renal vein. So we grab the artery from the periarterial lymphatics and then we pull it downwards, and then we dissect along the superior aspect of the renal artery until we reach the soft fatty layer. And we use the right angle towards the superior border of the artery so that the dissection is completed and we can apply a clip. I think it is now completed, so we can safely try again to apply the clip. And this time we are successful, and we check the vein which is not distending. So now we apply the Hem-o-log clips. Half close it and then bring it down and then apply. This is a technique which is really useful in the veins, so as to gain a good length, and another clip is used away from the major vessel, and now the third one can really easily be applied. So the next thing is to cut the vein so that the artery is exposed completely, and then we can complete the dissection of the artery. So the artery is now visible. We will try to dissect all around it. This will give us length, and this will also help us to dissect the posterior aspect of the renal artery, and we can then safely apply the clip. So the dissection is now complete. We can apply one or two clips. Here we applied a third one towards the major vessel, just to be sure, and then we cut the renal artery. We divide it, and then starts the dissection of the upper pole. We will surely remove this clip which is lying freely in the peritoneal cavity at the end of the procedure. Remember not to leave such kind of clips, especially the Liga clips, because they are notorious for migration into the gut. It can cause abscesses and so many things. Now we dissect the posterior aspect of the kidney as much as possible, so that only the peritoneal layer remains, and that can then be easily removed or dissected or cut later on. So we start with the peritoneum along the superior border of the artery. Always remember to dissect and cut in a horizontal rather than vertical portion. There are small vessels, especially veins, exchanging between the upper pole of the kidney and the adrenal gland. Here we are sparing the adrenal gland, as there was no evidence of any radiological involvement of the adrenal vein, and the tumor was in the middle pole, so we spared the adrenal. So when we are sparing the adrenal, we usually follow the course of the upper pole after mobilizing or dividing the pedicle. So the upper pole is now mobilized. Now is the turn to mobilize and free the kidney from the lateral aspect, as we have already dissected the posterior border of the kidney or the posterior surface of the kidney. It's really easily mobilized from the lateral aspect. So the dissection and mobilization of the kidney is now complete. The next step is to deal with the ureter. The ureter can be clipped with the Liga clips, or they can be clipped with the Hem-o-log clip, or it can just be coagulated with the ligashore at two different sites, distally and proximally, and then cut in between. However, here the ureter seems a bit thick, so the clip may not apply. So here we decided to coagulate it with the ligashore distally and proximally, and then cut the ureter, and then apply transfixation suture, intracorporeal transfixation suture, to deal with the ureter. You can see that the ureter is quite thick, and the Hem-o-log clip may not be applied. So a 2-0 Vicryl is used for transfixation. Because the lumen was visible, that's why we applied this suture. Otherwise, it may not really be necessary to clip the distal end. However, theoretically, cases have been reported, and theoretically there is a chance that this end of the ureter may start bleeding later on, leading to hematoma, or in case of reflux, that can lead to contamination of the peritoneum with the urine. So here you can see that it has nicely been transfixed using a 2-0 Vicryl, and suture is then cut, and after doing that we will place a drain which will be removed on the first or the second post-op day, and this marks the end of the procedure. Thank you very much.